First of all, I would like to thank the Sri Lankan Society of Nephrology for inviting me to this very important academic session. And I would like to also extend my greetings to all my fellow pediatric nephrologists here in Sri Lanka and the pediatricians whom I've met many years ago. It's really a pleasure to come back to your really beautiful country. So in my talk today, I'll be talking on lupus nephritis in children, novel perspectives. As you all know, that in children with systemic lupus erythematosus or SLE, there are higher rates of organ involvement. And in this, let me just get the laser pointer in. Okay. And in this graph here, you can see the bars in red are data on children in Singapore with lupus, with SLE. And you see that more than 70% of Singapore children develop kidney involvement as compared to only 50% in the adult population. Now, if you look at the adult situation in this large multi-site international cohort study, where having lupus nephritis is not a very good thing because you can see that the standardized mortality ratio is rather high, reaching about 8. Now, in hospitalized children in this study, you can see that the average adjusted probability of the first occurrence of any adverse renal outcome at a given hospital admission was higher in Asian children as well. So when you look at lupus nephritis, what is the long-term outcomes? So in this review, the rate of chronic kidney disease, stage 5, is reported to be up to 15% in children with lupus nephritis. And unfortunately for many of us, we probably follow them up to 21 years old and then we think we've done a good job. But in my old cohort, many of these children reach end stage when they are 30 or 40 years old. So it's very important that what we do in pediatrics is very important for the long-term final outcome for these patients when they grow up to be adults. So in today's talk, I will focus on these 3 points. Firstly, what are the challenges associated with traditional steroid-based treatment approaches in childhood lupus nephritis? Secondly, can steroid dose be minimized with the current multi-targeted therapy for lupus nephritis? And thirdly, can steroid-free management be achieved with the new biologics and targeted therapies? So starting with the challenges associated with traditional steroid-based treatment approaches in childhood lupus nephritis, I will start off with this case here. A 10-year-old boy who came in with multi-system involvement and was diagnosed with SLE. The first renal biopsy showed class 3 focal proliferative lupus nephritis, and he was initially treated with prednisolone, azathioprine, and hydroxychloroquine, and was apparently in some remission, even though this was probably only a partial remission. And he presented again 3 years later with hypertensive encephalopathy with a blood pressure of 200/111, and he had evidence of AKI and pulmonary hemorrhage, as well as evidence of thrombotic thrombocytopenic purpura. He was given IV phenytoin, intubated, and had to be dialyzed, and was given 12 sessions of plasmapheresis. And renal biopsy then showed class 4 lupus nephritis with 29% fibrocellular crescents and TMA. So he then received 2 courses of IV methylprednisolone with mycophenolate, followed by IV cyclophosphamide, but developed complications of pneumonia with acute respiratory distress syndrome. So I think many of you are familiar with this kind of cause of patients with lupus nephritis. So how do we actually treat them? So in diffuse proliferative lupus nephritis, we really approach just like in a treatment of cancers. We need an induction phase to try to achieve remission, where we try to restore kidney function, decrease the lupus activity, and decrease proteinuria. But very importantly, it's a maintenance phase to prevent progression of CKD. And this focuses on preventing SLE relapses as well as decreasing proteinuria. And what is very important in this very early adult study, it shows that kidney survival rates, as shown by this blue line in severe lupus nephritis, is actually worse in those who do not achieve remission after induction therapy, shown by this red line, as compared to the blue line, where if you achieve complete remission with no more proteinuria, the long-term outcome is very good. So steroid-based immunosuppression protocols have been the mainstay of treatment of lupus nephritis. And in this systematic review, which included 74 randomized controlled trials, including adults and children, of which 67 were on induction therapy and 9 on maintenance therapy. And what they looked at for the outcomes for induction therapy compared to IV cyclophosphamide was complete remission, end-stage kidney disease, and all-cause mortality. And you can see from this table here, using the various immunosuppressive protocols, that the combination of mycophenolate plus calcineurin inhibitor ranked as the best treatment to induce remission with the least side effects. Now, how about the outcomes for maintenance therapy? Again, the primary outcome included relapse after remission and end-stage kidney disease. And you see here that azathioprine was associated with more renal relapse, doubling of serum creatinine and leukopenia compared to mycophenolate. So therefore, this led to the current evidence-based treatment of severe proliferative lupus nephritis in adults. And these are the updates on the 2023 EULA recommendation, as well as the KDIGO 2024. But the first-line induction therapy, in addition to steroids, prednisolone plus or minus IV methylprednisolone and hydroxychloroquine. So the recommendation is to either have low-dose IV cyclophosphamide for 6 months, or a mycophenolate analog, or a mycophenolate analog or low-dose IV cyclophosphamide with IV belimumab, or an addition of calcineurin inhibitor. And this includes tacrolimus, cyclosporine, or the neovoclosporin. For refractory cases, you could switch to high-dose IV cyclophosphamide with mycophenolate or use IV rituximab. And the remission maintenance phase is either azathioprine or mycophenolate plus minus a calcineurin inhibitor plus minus belimumab. So what is the actual glucocorticoid effect? We now know that in the many studies on the effects of steroids, that it actually works through both a genomic effect where it acts through the steroid receptor, as well as a non-genomic effect to give you the immunosuppressive activity that you want. However, the steroid toxicity is primarily through the genomic effects. So basically, the genomic effects begin at prednisolone dose less than 7.5 milligrams, and glucocorticoid receptors are fully saturated around 30 milligrams of prednisolone equivalent. And the non-genomic mechanisms must be activated by high-dose prednisolone equivalent of about 100 milligrams up to a methylprednisolone equivalent of 1 gram to realize further immunosuppression without increasing toxicity. And clinical outcomes may not improve beyond cumulative methylprednisolone dose of 1.5 grams, but the risk of infection does. So therefore, when we talk about optimal steroid dose, we try not to go too high. At the same time, we cannot be too low, otherwise we do not achieve what we want. So what is a reasonable steroid dosing strategy for treatment of lupus nephritis? We need to induce both the genomic and non-genomic effects rapidly with IV methylprednisolone daily for 2 to 3 days to a maximum of 1 gram. And we need to then maintain with moderate dose prednisolone 0.3 to 0.5 milligrams per kilogram per day. And prednisolone reduction without antecedent high-dose methylprednisolone may not be adequate to treat severe lupus nephritis. So with this in mind, how do we treat our children with lupus nephritis? And in this international cohort of 382 children with lupus nephritis followed up for 24 months, you note here that all children received high-dose steroids, either IV or oral for induction therapy, as shown by this yellow box here, followed by a maintenance steroids in at least 90%. So you can see steroid forms the mainstay of treatment, and about 50% of these children achieved complete remission, as shown by this red line, while a further 30%, as shown by this blue line, while a further 30% achieve partial remission at 6 months. So steroids do work, but they do have some limitations as well. So let's come back to our case. What has happened to our patient? So he was finally transferred to our hospital for initiation of chronic dialysis, as his serum creatinine remained at 586, and the Tankhoff catheter was inserted and peritoneal dialysis was commenced. However, we continued on monthly pulse IV methylprednisolone for a total of 6 courses, together with mycophenolate as maintenance therapy. Over the next 2 months, his serological parameters of activity normalized with recovery of renal function, and his serum creatinine reached a baseline of 80 micromoles per liter and proteinuria of 0.29 grams per day per 1.73 meters squared. And today, 15 years later, he still has normal renal function. So what is the major concern in children with cumulative steroid-related toxicities. And in children, unlike in adults, they are growing, so short stature is a major issue. And I have boys who actually tell me they want to stop all treatment if I'm going to continue the steroids, because they really cannot be so short. So you can see that despite, including all the other complications which our adult colleagues see, I think growth is one of the very important problems. And we really need to do something about the daily steroid dosing which affects growth. In addition, when you look at the long-term steroid effect on bone mineral density in children, the red line here is the normals, and you can see that in children with SLE, this yellow line, they actually have very poor mineral bone density if we carry on treating with steroids on a daily basis. Unlike nephrotic children, when we give them alternate day treatment, they do much better. And you can see that those after a steroid withdrawal and those who have got alternate day treatment with steroids, their bone mineral density improves. So what is the problem with the current therapeutic regimens involving daily steroid dosing? You can see that intermittent IV cyclophosphamide for 36 months, which was what the high-dose protocol that used to be done, the NIH protocol. You can see that even though we can reduce the steroids, you finally still end up with a low daily steroid dose. So we haven't actually got away from the problems of steroid toxicity. So when you look at this graph here, which shows that the therapy of juvenile onset SLE results in decrease in activity over time, as shown by the yellow line, but it cannot prevent the damage scores, which is actually the steroid toxicity, for example. We cannot prevent that from accumulating over time. So can steroid dose be minimized with the current multi-targeted therapy for lupus nephritis? So in this adult study, the WIN lupus study, which looked at discontinuing immunosuppression therapy over 24 months versus a discontinuing over 3 months versus continuation over 24 months. So what they looked at was, for the primary outcome, was relapse of proliferative lupus nephritis at 24 months. So you can see here that patients who discontinued immunosuppression, meaning the drug other than steroid, whether it's mycophenolate or azathioprine, so it's shown by this yellow line, those who discontinued immunosuppression had higher risk of relapse of lupus nephritis and severe flares of lupus despite low-dose maintenance steroid therapy. So what this tells us that maintenance immunosuppressive therapy with mycophenolate to maintain long-term complete remission in severe proliferative lupus nephritis is very important. So with this in mind, we came up with this new protocol for our patients, and it was really triggered by the boy who told me that he was going to stop all medications unless I did something about it. So we came up with this protocol where we use pulse IV methylprednisolone up to 6 pulses monthly, 6 months, with mycophenolate to induce remission, and those in whom they continue to have proteinuria after 1 month but with normal creatinine, we added a calcineurin inhibitor, and in those days we added cyclosporin. And our aim target was to achieve a proteinuria remission of less than 0.3 grams per day, basically complete remission. And in this process, we were able to start with low-dose prednisolone, never more than 30 milligrams per day, and basically at 0.5 milligrams per kilogram per day, and taper this rapidly to an alternate day regimen. And in many of them, we could even stop the steroids completely. And remission was really cyclosporin. Remission was really with mycophenolate, and our cyclosporin, we stopped it once proteinuria remission has been achieved. So what is the difference between IV methylprednisolone pulses and oral prednisolone? We know that IV methylprednisolone in studies have shown to kill plasmacytoid dendritic cells that makes the type 1 interferons, which are the major driver of lupus. And these dendritic cells, unfortunately, regenerate in a week, implying that repeat pulsing may be useful in inducing remission. So with this in mind, with our combination of pulse methylprednisolone, mycophenolate, and cyclosporin, you can see here that it's an effective therapeutic alternative for induction. There's a decrease in SLE disease activity index, decrease in proteinuria to normal, decrease in hematuria to negative, and a rise in serum complement. In other words, normalization of serum complement. So what happened in the long term with these patients? So we followed them up for a median of 9.2 years, and all children achieved complete remission within 24 months. And you can see from this table that at least 37.5% of them were completely off steroids, and another 50% were maintained on low-dose alternate day steroid therapy. So this way we could avoid much of the steroid toxicity, and what happens is that these children can then grow. So you can see that the cumulative relapse-free proteinuria survival at 10 years was 73.3%. And this is really related to the fact that they had to take daily mycophenolate. And as you know, when a child feels very well and when they're adolescents, they just stop taking their medicine sometimes. And patients treated with mycophenolate and cyclosporine, this multi-targeted therapy, they fared better in terms of growth as shown by the height SDS scores comparing the days when we were using cyclophosphamide and azathioprine versus mycophenolate and cyclosporine. So coming back to our case, what has happened to him? His steroid dose was gradually tapered over 9 months, and he went on to alternate day therapy and was finally discontinued 8 years later. And he was maintained on mycophenolate, and he was able to grow and cross the 3rd percentile up to the 10th percentile of growth. So this was very important to that boy. So the last question I want to ask here is, can steroid-free management be achieved today with the new biologics and targeted therapies? As you all know, the anti-CD20 antibodies against the B cells like rituximab and obinutuzumab is now one of the standard of care for lupus nephritis. And looking at this systematic analysis comparing the effectiveness of rituximab and common induction therapies for lupus, you can see that rituximab and mycophenolate were the most effective drugs for inducing complete remission in lupus nephritis here, but rituximab had the highest infection risk. In the UK juvenile SLE cohort study, they managed to demonstrate a reduction in albuminuria following rituximab treatment in children with lupus nephritis. And when they looked at side effects, really there were very few significant side effects, only a 2% infection risk, including CMV and herpes zoster. Now, so this has led to this systematic review for the use of rituximab in the management of pediatric SLE, that rituximab was able to exhibit a satisfactory profile regarding efficacy and safety. Now, how about the other B-cell directed therapies like belimumab, which acts against the B lymphocyte stimulator pathway? You can see here that in this systematic review, which included 2 randomized controlled trials, what they showed was that there was a 1.71 higher odds of complete renal response in the belimumab group, but no significant differences in treatment-related adverse events. And when another systematic review looking at belimumab therapy in SLE itself, not just restricted to lupus nephritis, you can see that belimumab significantly reduced the prednisolone dose by 50% or more than placebo at 52 weeks. And this has therefore led to the adult guidelines of using IV belimumab to try to reduce steroid doses in those who are taking really high dose steroids. Now, how about new pathogenetic targets of to target the treatment of SLE? You can see from this slide here that in addition to the anti-CD20, the anti-B cell activating factor monoclonal antibodies, there are now also antibodies against interferon alpha like anifrolumab, which has just received FDA approval for the treatment of SLE. Again, there are new calcineurin inhibitors like voclosporin, which are a bit more efficacious. And what is important, you don't need to monitor levels. So this can then be used in multi-targeted therapy, not only against the immune system, but against the podocyte. Because we know that the calcineurin inhibitors do modify the actin skeleton in the podocyte itself to help in control of the proteinuria. In addition, there are other monoclonal antibodies against IL-17, which stimulates B cell production of the autoantibodies. So again, this has been on trial and has been used in other diseases like psoriasis. So it remains to be seen how useful this will be in treatment of SLE. And again, small molecules like the tyrosine kinase 2 inhibitor, which again affects all these pathways. So I think moving forward, there are many new potential therapies that target the immune system that may allow us to really cut down the use of steroids in our patients. So what are the recently completed clinical trials of new therapies for lupus nephritis? The Nobility trial looked at obinutuzumab, which shows greater complete renal response. The Tulip trial, which used anifrolumab, again, this showed a higher complete renal remission. The oral LV phase 2b trial with voclosporin, again, it shows a higher complete remission rate with low-dose cyclosporine as well. So again, all these new therapies do show promises, and some of them have now weaved their way into the adult guidelines for treatment of lupus nephritis. Now, how about the future? What is this new kid on the block? So recently, there has been anti-CD19 CAR T therapy for refractory systemic lupus erythematosus. So this target to eliminate the B cells completely and the plasma cells which produce the autoantibodies. So in the trial, the pilot trial here, you can see that they had 5 patients with severe proliferative lupus nephritis, and they all managed to get their disease activity controlled. So you can see that most of these patients had very high disease activity score, and all of them had stage 3 or 4, in other words, a proliferative lupus nephritis. So what happens is that they are able to induce drug-free remission of SLE following treatment with CAR T therapy. You can see from this slide here that the disease activity scores came right down to 0, and they actually had control of proteinuria, complements got better, anti-DS DNA antibodies disappeared, and these patients felt much better in terms of the symptom of fatigue. So in conclusion, I would like to just leave you with these messages. The SLE in children has a higher rate of major organ involvement, especially lupus nephritis. Patients with proliferative lupus nephritis have poorer long-term outcomes in terms of renal survival if they do not achieve complete renal remission. And steroid-based treatment protocols together with immunosuppressive agents, which are the mainstay of treatment in children with severe lupus nephritis, are associated with significant side effects from the steroids, in particular growth retardation. So protocols involving stabilization of disease with mycophenolate and calcineurin inhibitors and minimization of steroid dose tapering to alternate day or discontinuation results in improvement in height velocity. And use of biologics such as rituximab and belimumab and other novel therapies may allow steroid minimization or steroid-free management of lupus nephritis. And in the future, drug-free remissions are potentially possible with the new CAR T therapies. So thank you very much. And what is very important is that we need to look at each patient individually and manage the patient and not the disease. Thank you very much.
To thank the President and the Council of the Sri Lanka Society of Nephrology for the invitation. It's a great pleasure and a privilege to be here. Now, I'm going to deal with steroid-resistant nephrotic syndrome. And during the course of this lecture, I'll be introducing you to the topic. We will be dealing with definitions, touching on genetics, dealing more with the non-genetic forms of SRNS with remission induction and symptomatic therapy. We'll touch on some of the novel therapies and finally end with prognosis. Just to rush through the introduction, you all know childhood nephrotic syndrome is characterized by massive proteinuria, hypoalbuminemia, edema, and hypercholesterolemia. Commonest glomerular disease, it's a commonest glomerular disease in children, characterized by a relapsing and remitting course, unlike in adults where you get rumbling proteinuria. Corticosteroids are the mainstay, and steroid resistance, however, is seen in about 10 to 15%, which we will be touching on today. Epidemiologically, this is what is important, but the last point is probably of concern to us. Nephrotic syndrome is 6 times more common in the UK Asian population, and not only is it more common in Asians, it tends to be more severe with more dependent and more resistant disease in Asians. Course-wise, about 20 to 30% have a single episode, 60% have relapsing disease, and 10 to 15% have steroid resistance. But the resistance rates are significantly higher in Asians and South Asians, again, important in our context. Histologically, minimal change is the commonest disease, but when you consider steroid-resistant disease, FSGS and idiopathic mesangial proliferation occur in significant proportions. Now, what is known about nephrotic syndrome? The guidelines and management protocols are largely dependent on this international study of kidney disease in children, which was a large-scale study done in the 60s and 70s involving a large cohort of patients. Now, they defined steroid-resistant disease as the failure to attain remission within 4 weeks of prednisolone at 60 milligrams per meter squared. The German group APN also goes by this definition, but later on, The French-speaking group of nephrologists, nephrology, dialysis, and transplantation added on three pulses of intravenous methylprednisolone to this 60 milligrams per meter squared for 4 weeks. This is what we practice at Peradeniya, and I believe this is what is practiced at Great Ormond Street and Manchester as well. You also need to know the difference between primary resistance and secondary resistance for the trainees. Primary resistance is where you're resistant in the first episode itself. Secondary resistance is where you are initially sensitive and subsequently develop resistance. Now, just to exemplify as to why the 3 pulses of methylprednisolone are important, the majority of patients will enter remission within 4 weeks of therapy, but there is a minority of about 3% who require a little more steroids to go into remission. And by giving these 3 pulses of methylprednisolone, you'll be able to catch that 3% of patients, and that is without dragging on the steroids for too long. And if they do not respond, you can start the CNI or the remission induction agent earlier. Steroid resistance, you get the genetic forms accounting for around 20%, and the non-genetic forms, immune-mediated forms, accounting for the vast majority. And we'll be mainly dealing with the immune-mediated forms. Just to touch on genetics, just for completion, these are the genes involved. There are more than 70 genes involved in steroid-resistant disease. The nephrin and podicin mutations in PHS1 and 2 are probably important, as is PLCE1 and WT1. Syndromic forms of SRNS, many syndromes are associated with steroid-resistant disease, and these are the genes that are involved. Now, when should you do a genetic test? Now, genetic tests are not freely available in this country, but we should try to get them done when the patient is primarily resistant. When the patient has primary steroid resistance, genetic tests are definitely indicated. If your patient has familial FSGS, or if the patient is syndromic, again, genetic tests are definitely indicated. And when the patient responds to steroid, does not respond to calcineurin inhibitors, even in the ones with secondary resistance, if you do not respond to calcineurin inhibitors, again, genetics are beneficial. Prior to transplantation, it is of extreme benefit because the prognosis for the genetic forms is much better post-transplant than the immune-mediated forms. So for prognostication, genetics are extremely useful. Now, this elusive permeability factor is what is thought to cause FSGS and steroid-resistant nephrotic syndrome. Circumstantial evidence for this arises with children with SRNS who undergo transplant having a rapid recurrence of disease, and they respond very well to plasma exchange, which is thought to remove this permeability factor. Mice who have been injected with plasma from patients with steroid-resistant disease develop proteinuria, again, indirect evidence that there is some factor. But still, this factor has been elusive. Some of the molecules implicated are listed here. Right, so for the trainees, when your patient is resistant to nephrotic syndrome after 4 weeks of prednisolone plus methylprednisolone, if you're using it, you need to look for other causes because it's not likely to be non-minimum change disease. So you need to do your streptolysin antibodies, complements, look for lupus with ANA and double-stranded DNA. Hepatitis serology is important, as is HIV. And we also need to do the VDRL because syphilis is on the rise, and syphilis does cause steroid-resistant disease. Light microscopy and light microscopy and immunofluorescence is needed for your renal biopsy. These are essential, as is electron microscopy. But in this country, electron microscopy is not available in the health sector. It's available in the archaeology and geology departments because the dead are more important than the living. And genetic studies are definitely indicated if your patient is primarily resistant. Treatment-wise, your aim is to achieve complete remission. And this is when your proteinuria is negative and the UPCR is less than 0.2. Partial remission is when the UPCR is between 0.2 and 2, with a serum albumin of more than 25, with no edema, and no response is classified when the UPCR is more than 2, albumin less than 25 with the presence of edema. This is important prognostically. Now, calcineurin inhibitors are the drug of choice for steroid-resistant disease, and this has been proven beyond doubt to be the first-line remission-inducing agent for these patients. They act through inhibition of T lymphocytes, and the response, and they also importantly have an antiproteinuric effect because they stabilize the podocyte cytoskeleton. Response, depending on the histological types, is similar, with minimal change disease having a slightly better response. And it is important to remember that once a patient goes into remission with cyclosporine, subsequent relapses can be treated with steroids. So it doesn't mean that you are not going to be able to use steroids again. So you can treat these relapses with steroids, and they become secondary steroid sensitive. Drug concentrations are obviously affected by cytochrome P450 inhibitors. So macrolides, azole antifungals, and grape juice and pomegranate juice. Yeah, grape juice and pomegranate juice. They are two things that tend to increase the dose of the CNIs, the levels rather. Cyclosporine versus tacrolimus, efficacy-wise in inducing remission, both are similar, but tacrolimus has a slightly lower relapse rate, subsequent relapse rate. So that gives it a slight advantage. Cosmetic side effects are definitely better, with definitely more with cyclosporine, but tacrolimus has significant diabetogenicity. And when you're using it with high doses of steroids, many older children tend to develop glucose intolerance. These are the target trough levels for the two drugs, and the duration is, it's difficult to define because you need to give them for quite a long time. And something that I tell my trainees often is that cyclosporine is like Pringles, the potato crisp. Slogan being, once you start, you can't stop, right? So cyclosporine also, once you start, you can't stop. Right, so these are some of the other methods of treating steroid-resistant disease. So the CNIs, cyclosporine and tacrolimus has very significant remission induction capabilities. Cyclophosphamide, according to the KDIGO guidelines, has no place in steroid-resistant disease, but before cyclosporine came into being, cyclophosphamide was used, and it was quite successful. IV cyclophosphamide is definitely better than oral cyclophosphamide. This is the Mendoza protocol. It has significant benefit, but with tremendous toxicity because you use very high doses of steroids for long periods of time. Right, rituximab. We've heard about its use in SLE. It's the anti-CD20 monoclonal antibody, depletes B cells. It is extremely effective in steroid-dependent disease. It also has an antiproteinuric effect by stabilizing the podocyte cytoskeleton, but the efficacy in steroid-resistant disease is extremely controversial. There are some studies that have shown benefit, some studies that have shown no benefit at all. I, for one, am very skeptical about the use of rituximab in steroid-resistant disease, and this is because rituximab may be, when the patient is proteinuric, rituximab being a protein, it may be lost in the urine, so it's difficult to maintain levels. But, however, there are many studies that have shown benefit, and the ones that have shown benefit, as I listed here, a lot of studies have not shown much benefit, but there are studies that have shown significant benefit. And these studies have used rituximab earlier in the course, say within the first year of diagnosis. And they also have given repeated courses of rituximab, which probably helps to keep the levels at a steady state. So there may be a point to start it early and use it frequently. Just to summarize as what we have just taught, so if your patient is, you treat your patient with prednisolone, remission is achieved, treat as a steroid-sensitive case. No remission, start CNIs. With CNIs, you go into remission, fine. No response, you can add on MMF or you can give rituximab. No response, there's high risk of end-stage disease. If there's no response to CNIs, also you need to do the genetics. If the genetics are positive, you need to come off or reduce your immunosuppression. Symptomatic therapy, I've just touched on this, given this slide for the benefits of the trainees. You need to you need to manage your edema, and remember that these patients will need diuretics, sometimes long-term, and off and on they would need albumin as well. But the decision to give albumin is always a clinical one. It is not based on the serum albumin level. These patients, because of the constant proteinuria, they readjust their Starling forces. So even with an albumin of 10, they can maintain good circulation. So you don't have to give albumin. But if there is circulatory compromise, albumin is required. Residual proteinuria I'll be dealing with. Infection prophylaxis, we tend to use penicillin prophylaxis if the IED matters, and vaccination is important. Thrombosis, certain units do use a little bit of aspirin low dose to prevent thrombosis, if the IED matters. Hyperlipidemia in these patients needs to be addressed, in my view, though there's conflicting evidence to this. This is because in steroid-sensitive disease or hypercholesterolemia is transient, these patients have persistent hypercholesterolemia, which can reach very scary levels. Atorvastatin is what we frequently use, but rosuvastatin has been shown to be more beneficial. You need to screen for thyroid disease because thyroid binding globulin is lost in the urine, and they can develop hypothyroidism. There is little evidence for vitamin D supplementation, though vitamin D levels can be lost. So ACE inhibitors reduce proteinuria by 30 to 40%. If you add on an angiotensin receptor blocker, you can achieve a further 10 to 15% reduction in proteinuria, but this runs a tremendous risk of hypotension and hypokalemia. Always remember, if your patient is hypovolemic, say develops diarrhea and vomiting, the first thing you should do is stop the ACE inhibitors temporarily. Let's move on to the novel therapies. We've got pharmacological agents, we've got extracorporeal agents, which are not really new except for lipid apheresis, and stem cell transplantation I'm not going to deal with today. So what are the new pharmacological agents? The first two are not new, they are age-old therapies, but have lately shown some response in patients with steroid-resistant disease. The tongue twisters or the biologics, ofatumumab, adalimumab, and abatacept. I did quite well there. So these are new agents, but one must remember at the outset that these are all very small-scale studies that have dealt with only a small number of patients. And also, there is obviously going to be a selection bias where the patients who respond are reported, but there may be a multitude of patients who have not responded and have not been reported. So whatever is discussed needs to be taken with a pinch of salt. ACTH, it acts by inducing steroids. It also has effects on the podocytes and the glomerular cells. It stabilizes the podocyte food processors, reducing proteinuria. It has immunomodulation, and also by acting on the glomerular cells, it stabilizes your glomerular function. Immunomodulatory properties are useful, again, with regard to inducing remission in resistant disease. And ACTH has been shown to be beneficial in steroid and multi-drug resistant disease. Galactose is thought to act by binding this elusive permeability factor. And this phase 2 clinical trial showed benefit in 3 patients who achieved reduction in proteinuria, and the effect lasted between 3 to 12 months. Again, small-scale studies. Ofatumumab is a humanized form of rituximab, or humanized anti-CD20 antibody. It has shown efficacy in rituximab-resistant disease and rituximab intolerance. This is one of the studies that has shown this. And here, 4 out of 4 patients that were treated with ofatumumab, 3 achieved complete remission and 1 achieved partial remission. Adalimumab is a TNF-alpha inhibitor, and TNF-alpha has been shown to be active in FSGS. The FONT study, which dealt with adalimumab, showed some response in a few patients. Abatacept is an inhibitor of T cells. It acts by acting on this B7 molecule, which is thought to be active in glomerular diseases. And in this study, in FSGS patients, there was some benefit. Right. Extracorporeal therapies, just to rush through. Plasma exchange has been conducted. It's not a new therapy. By no means is it a new therapy. It has been used for severe steroid-resistant disease, multi-drug-resistant disease, and it acts by removing this elusive permeability factor. And this review showed significant response. This study by D'Amico showed a response in quite a significant number of patients. Immunoadsorption is a slightly more refined form of plasma exchange, which uses high affinity absorption columns to remove molecules more selectively. Again, in this review article, this study showed quite significant benefit when used in FSGS patients. And finally, I'd like to just deal with lipid apheresis, because this is a new therapy that has come into being. It removes the lipids, and removal of lipids is known to reduce proteinuria. This is why patients with obesity have proteinuria. It has it removes the lipotoxic effect. So lipids are known to cause glomerular and sclerosis and interstitial fibrosis. So that effect is lost. When you remove your lipids, you know your calcineurin inhibitors are lipophilic agents, and they bind into lipids. So when you remove the lipids, your calcineurin inhibitor levels are improved, and this also helps with remission induction, and it has anti-inflammatory properties as well. So this is why lipid apheresis is important, and these studies all have shown quite significant benefit with lipid apheresis. Just rush through prognosis as we're running as we've run out of time. 10-year survival in patients with steroid-resistant disease for genetic causes is very poor, but for minimal change, it's relatively acceptable. 10-year survival with regard to response to therapy. If you do respond, you do well. No response, you do not do well. So in summary, steroid-resistant disease poses a significant therapeutic challenge. CNIs are the drugs of first choice. Supportive therapy is important to improve the outcomes of these patients. Novel therapies include extracorporeal lipid apheresis and biological agents, and prognosis greatly depends on the response to therapy. Thank you.
So today's session, I'll be talking about vasculitis, and specifically renal vasculitis in children. And obviously the reason we're doing this is because it's an important cause of presenting glomerulonephritis. Now, I've got no specific conflict of interest or disclosures to make. Now let's set the scene for vasculitis and why it's relevant to pediatric population. So what we can see on this slide is a figure recently published from the Norwegian Kidney Biopsy Registry. So this is a national registry where they collect all the data on kidney biopsies done in children. And so this is just showing the number of biopsies with specific diagnoses over many years. You can see, not surprisingly, the main indication for biopsy in children has been nephrotic syndrome, so minimal change diseases at the top there, and FSGS as well. But I've put the arrows in because it is showing really the vasculitises. And so at the top is IgA vasculitis, which previously called Hinoch-Schönlein purpura, ANCA vasculitis, and then it should be GBM, anti-glomerular basement membrane antibody. Now today's talk, I'm going to mainly focus on these two, IgA vasculitis and ANCA-associated vasculitis. Another way to look at it is to think about children who have crescentic glomerulonephritis. So this is usually children presenting with rapidly progressive glomerulonephritis, and the biopsy shows that they've got crescents. This is from our Indian colleagues, is a systematic review of international studies on children. You can see there's 1,500 children were involved in all these studies. And just looking at what's the etiology, they looked at other things in the paper, but this I've just put up here, the table showing etiology. And you can see that immune complex, so maybe some of that might have been vasculitis, some of them might have been lupus, some might have post-infectious. But really the ones that are clearly labelled as vasculitic is, again, IgA vasculitis, porcine immune, which are mostly the ANCA-associated vasculitis, and anti-GBM. So making a significant proportion of children who have rapidly progressive glomerulonephritis. Even though altogether it is a rare disease in children, vasculitis. So it's rare in adults, but even rarer in children. Henoch-Schönlein purpura, or IgA vasculitis, is the standout one. It's the commonest vasculitis we see in children, and it's much more common in children than adults. But ANCA-associated vasculitis, very rare in children, and glomerular anti-GBM, or Goodpasture syndrome, is even rarer still. In terms of understanding vasculitis, it's important to think of the classification and the diagnosis. This is the long-standing classic definition, categorization of vasculitis from the Chapel Hill group, and it's based upon the size of vessels involved, going from large vessel to medium-sized to small vessel. It basically based mainly on adult patients. There's a bit of a modification of it from mainly the European rheumatology groups to modify it for children. So again, large vessels, so Takayasu's, medium vessels, particularly in children, Kawasaki's, but it's the small vessel vasculitis that causes the glomerulonephritis. Some of the medium vessel diseases, they can certainly present with glomerulonephritis or kidney disease, sometimes the polyarteritis, but it's the small vessel ones that are the main issues. And the ones I've got in red there are the ones that I'll talk about today. The categorization obviously breaks them down into granulomatous or non-granulomatous. There's also vasculitides that are secondary to other diseases, particularly infectious diseases, and particularly viral hepatitis being an associated one, and drug-associated, and I'll mention that briefly at the end. So our most common vasculitis in children, we've all seen it. Anyone practicing pediatrics would have seen a young child presenting with widespread purpura, particularly over the lower limbs. Also, when they present, they've often got swollen joints, swollen ankles, knees. They might have difficulty walking. That's frequently got abdominal pain. And if you do a urinalysis at that stage, they probably have a clear urine when they first present. But the significant number of them, and we'll talk more about it, will go on to develop some renal involvement. So the diagnosis is based on purpura plus one of the other signs. The histopathology can either be renal or skin biopsy would be the other thing. Why do children get IgA vasculitis? Well, what we can see epidemiologically is that there are seasonal peaks, particularly in spring and winter, and there have been many case reports, case series linking it to infections, common infections in children, less common ones, but there's plenty of reports of it in Campylobacter, gastroenteritis or colitis, mycoplasma infections, Helicobacter infections. There's several reports of it associated with that, and more recently COVID-19, all seen as potential triggers for this. But most of the kids that come in, yes, they may have been a bit unwell, but there's no clear trigger. The pathogenesis is, if you were at the meeting yesterday, there was a lot of talks about IgA, and this is the 4-hit sort of pathogenesis of IgA nephropathy, which is very similar in IgA vasculitis. So really the first hit is we've got the abnormal galactose deficient IgA circulating, and then that's triggered, and then that causes the kidney, the vasculitis, which of course causes glomerulonephritis. I'm not going to go into too much detail. Now, making my talk easy is the recent publication of this guideline. So the International Pediatric Nephrology Association, which I hope you're all members of, so IPNA has started the process. You might have seen a couple of the guidelines where they're getting experts, us, pediatric nephrologists from around the world, to come together to work on consensus evidence-based guidelines about common pediatric diseases. This is just published about IgA. So both IgA nephropathy and IgA vasculitis. And I'll run through a few of these recommendations and explanation. To give the background, they base it on evidence from high through to low, very low, and then make a recommendation. So first, one of the things to start with, to say that, okay, the renal involvement is common in IgA vasculitis, but most kids have a mild kidney disease. It's only a minority that will go on to significant nephritis, which we really need to intervene. As you know, most children with IgA vasculitis will spontaneously resolve. The purpura will resolve, the abdominal pain will resolve. But things that may give us a clue that they're going to go on to have more severe kidney disease would be more severe involvement of other organs, particularly GIT, recurrent episodes, so the kids that get repeated episodes of purpura, they develop proteinuria early, and also older children. And in adults, HSP is often more severe than in children from a renal point of view. So because of that, we need to actively monitor any child who's got the diagnosis for potential renal involvement. And that's really clinical monitoring, including with urinalysis. In terms of frequency of how often we do a urinalysis, this guideline I thought was fairly conservative. To do it at onset and then monthly, and then regularly up for monthly for 6 months. But in practice, we do it a bit more frequently in the first month, so maybe weekly at a minimum, I would suggest. When do we do a kidney biopsy? So the reason for doing a kidney biopsy would be to confirm the diagnosis potentially, but more importantly to guide management. Now, you can see just looking at the evidence statements, there's not a lot of evidence. So grade D is very poor. And these recommendations range from weak to moderate. But in general, so what, if you can read it, what they're suggesting is we should do a kidney biopsy for a child who's got reduced GFR. We should do a kidney biopsy for a child who's got moderate proteinuria for 2 to 4 weeks, or even lower grades of proteinuria for beyond 4 weeks. Once we've got the biopsy, how do we interpret it, or how does the pathologist interpret it for us? So as Prof Shenal was mentioned, the international study in kidney disease in children has previously developed a grading system for IgA vasculitis, which you can see on the left, which goes through really based on the presence and the amount of crescents in the biopsy, from no crescents in grade 1 or 2 through to less than 50%, 50 to 75%, greater than 75% crescents. There's another system which is based on the Oxford system, which was used for IgA and now also used for IgA vasculitis, which I think gives you a little bit more information. It's a bit more refined because, yes, it includes crescents, that's the C, but the MEST tells us a bit more about activity, which in particular the endocapillary proliferation and chronicity in terms of sclerosis and interstitial fibrosis. So based on clinical and biopsy findings, can we predict outcomes? So meta-analysis in 2019 pulled together several studies and looking at, these are the factors that are frequently identified. So age, so older children had more risk of progressing to an unfavourable renal outcome, which of course the definition will change with various studies. Presenting with a lower GFR initially, which makes sense, and having nephrotic range proteinuria is a poor sign. But also in terms of biopsy, it was the presence of crescents. So the ISKDC grading 3 to 4. So any crescents really. Just published this year is a large international study which includes, you can see 262 children and almost 100 adults, which used the MEST-C grading system instead of the ISKDC. And the main takeaway from this is that it showed, so 2 groups, they identified really two groups, those who have decline in GFR, those who have stable GFR. And the group that had the decline in the GFR, the scoring on E in the MEST-C system, which is endocapillary proliferation, that predicted worse outcome. So It's that activity that's going on in the kidney at the time of the biopsy. So if we're going to treat IgA vasculitis, how do we do it? Well, this is a great recommendation, statement from the guideline. It was unable to draw any evidence-based conclusions on the treatment, and that's because of a lack of evidence. Obviously, these are small studies. It's mostly retrospective, frequently short, small case series. But the aim of treatment is to reduce proteinuria and obviously to protect the kidneys. We shouldn't be using immunosuppression for a child who doesn't have proteinuria. If there's higher grades of proteinuria, then you can see weak recommendations to treat. And the treatment is based on corticosteroids. And again, a weak recommendation that if you need to use other immunosuppressants, you can basically try anything almost, because there's so little evidence. But really, crescentic glomerulonephritis, cyclophosphamide often been the mainstay. So how do we use corticosteroids? It's quite similar to how Prof Yap talked about it for lupus nephritis. It's a high dose initially with IV methylpred. And then it's a 4 to 6 month course, usually, of oral steroids. But again, like in lupus, we try to minimize, try to use a lower dose. Many protocols are using the sort of things that we'd use for nephrotic syndrome, 2 milligrams per kilo, 60 milligrams per meter squared. But I think you can use a lower dose after you've given the IV methylpred. And then wait and be patient, because it does tend to settle down. But some children won't, and rarely you'll need to introduce other immunosuppressives, suppressants. It could be mycophenolate, azathioprine, calcineurin inhibitors, very little evidence. And also if there's prolonged proteinuria, then certainly an ACE inhibitor. And this is just to remind you that in adult studies in lupus, there's in IgA, there's clearly shown the benefit of lower doses of steroids. So what I'd use is usually like more that alternate day after giving methylpred, and like a 0.5 milligrams per kilo alternate day. Okay, so that's IgA vasculitis, and the other vasculitis I wanted to look at was the ANCA associated. So ANCA is anti-neutrophil cytoplasmic antibody. So this is a site of immunofluorescence of neutrophils. And so C ANCA is cytoplasmic ANCA, where there is widespread diffuse staining of an antibody within the neutrophils. And P ANCA is perinuclear, where it's just slightly different distribution of the antibody. The other way you can measure ANCA is using ELISA to actually measure the antibody, and identify that the target for these antibodies are antigens that are in neutrophils, proteins in neutrophils, proteinase 3, which is PR3, and myeloperoxidase. Now, in terms of disease types, we know there's 2 types of this small vessel vasculitis that affects the kidneys. The granulomatosis with polyangiitis, which previously was known as Wegener's granulomatosis, and that tends to be PR3 positive. And the microscopic polyangiitis tends to be MPO positive, but there is some overlap there in terms of the ANCA positivity. And both, though, can cause a crescentic glomerulonephritis. The pathogenesis is complex and quite interesting, and I won't go into it in detail, but I'd refer you to this paper if you're interested in it. Richard Kitching, the main author, is a paediatric nephrologist from Melbourne, does a lot of research in animal models. But it's a really comprehensive overview of ANCA-associated vasculitis in adults and children. But basically, there's a trigger. I think there's a trigger which may be infectious. There's the loss of tolerance to these normal proteins become the antigens. So then we have autoantibodies against those proteins. And there's triggers the vasculitis, which involves both neutrophils as the main effector cells, but T cells are also involved. So the clinical signs are multi-system. So the kidneys, glomerulonephritis. There's 3 types on this table. The other one that we've got here is EGPA, which is eosinophilic granulomatous polyangiitis, which used to be called Scherk-Strauss, which more gives respiratory changes and asthma. But lung involvement can be seen in all these vascular disease, with pulmonary hemorrhage in particular. and really upper respiratory tract changes, which are much more common in GPA. There's recently been a few papers that have looked at small groups of children with vasculitis. And I've just summarised these on this table to give a bit more of the epidemiology in children. So these are sort of single or small centres, well, not this, so this single centre, this is a small group from California. They're all paediatric nephrologists. These three national studies involve rheumatologists and paediatric nephrologists, so that might explain some of the difference in epidemiology. But you can see the mean age of presentation of these children ranges from 10 years in China, but again, it's a big group, including not all renal involvement, to 14 to 15 years. There is a female, it seems to be in children, a female predisposition, but whether it's the MPA or the GPA, it varies a bit, but probably in at least East Asia, there's more of a tendency to have MPA rather than the granulomatous form. In terms of treatment, again, there's another recent guideline or an updated guideline from KDIGO, which specifically looks at ANCA-associated vasculitis. I'll just run through this very quickly, but just to summarise, so the treatment for induction of vasculitis is either rituximab or cyclophosphamide traditionally. And as you can see, it suggests that in children and adolescents who use rituximab, that's mainly because of the adverse effects on fertility of cyclophosphamide. The rituximab is, so the other thing that's mentioned here is this drug called avacopan, and I'll talk about that. But it's a chronic disease like lupus, so we need induction therapy, then we need maintenance therapy and try to limit the toxicity of maintenance therapy. Avacopan is a drug that targets the complement system and the terminal component of complement, particularly the C5a receptor. It's an antagonist there. So it's sort of down the end of the pathway where eculizumab works, but it's less, there's more specific and possibly has less side effects. It can be given orally. And it's been shown to be effective in adults with ANCA, but very little data in children. So I did a quick literature review to look at for ANCA in children, for avacopan in children. And this is there's a message in this thing. So we've got one case report just last year about a different disease, C3 glomerulonephritis. They said it was successful. But then soon after, there's an international trial in C3 glomerulonephritis that said it's not successful. So we've always got to be careful in paediatrics particularly, because there's so little data, how we interpret a case report. Then also just recently published a case report from Japan where they were treating a child with GPA with avacopan. And that child developed an acute hepatitis. And so I think it's just telling us that we've got to be very careful with these new drugs in children. So the avacopan was given along with rituximab. There was a reduction in PR3, but after a very short period of time, just days, this child had an acute hepatitis, which resolved when the drug was withdrawn. Just very briefly, often used antibiotics to prevent relapses of Wegener's granulomatosis, but there's no evidence to suggest that it works, but it does prevent infection. And finally, the drug-associated I mentioned, we can see drug-associated ANCA in the children that we're treating with levamisole for steroid-responsive nephrotic syndrome. This is from our centre, where we show that about 18% of them developed a positive ANCA, and a small number had a vasculitis, which improves when you withdraw the drug and treat them with steroids. And just very recently, a larger study from India showing very similar results. 18% developed ANCA positivity, and it increases the longer you have these children on levamisole. So it's just something to be wary of. So that's it, very brief summary of those two diseases, IgA vasculitis and ANCA positive.